So PAO basically means periacetabular osteotomy. In essence, it's an osteotomy of the pelvis, which is basically creating controlled fractures of the pelvis and realigning the socket part of the hip. Now, patients with hip dysplasia typically have a socket which is perhaps too shallow or is pointing in the wrong direction. And the periacetabular osteotomy as a procedure aims to correct that. So in simple terms, yes, it is a controlled fracture of the bone and reorientation of the acetabulum such that it's in the perfect position so that the hip can function at an optimal level. So typically, these are young patients, typically females who have presented with hip pain, and this pain has been going on for a long time. And that the pain will be in the groin area, sometimes the outer aspect of this, sometimes the buttock area, and it would be activity related and it would be progressive. Some patients will also have instability type of symptoms where the hip may feel a bit loose. They may have sticky feeling in the hip. In essence, however, we have to examine the patients such that we can find out if it is the instability causing the hip pain or indeed impingement. Now, impingement has a different solution, while instability, the solution would be a periacetabular osteotomy type of operation. Perhaps periacetabular osteotomy is one of the most complex operations that can be done for someone's hip problems. There are very important nerves and vessels around the hip that stand a risk of getting damaged. Now, the risk is there, but it is quite low with the conventional treatment in the form of minimally invasive osteotomies. And then there are obviously precautions that we take to mitigate those risks. Clearly, then, if you are fracturing someone's bone, they may bleed as well. So bleeding risk is also there. The most common risk, however, is some degree of residual pain related to non-healing issues. So if you are a smoker, if you've got high BMI, if you overdo it in the first few weeks, the bone may not heal. And that is the most worrying risk, at least that I'm worried about. And I do counsel patients to actually look after the hips in the beginning. Then there are other smaller risks, which again can be reduced by good patient selection and good quality rehabilitation. It is all individual dependent. But typically, I would expect patients to be using crutches for around 3 months. For the first 6 weeks, they are not allowed to put full weight through the leg, just a little bit of weight, and then we progressively increase the weight bearing such that by the end of 3 months, they are fully weight bearing and walking independently without any walking aids. But clearly, the hip wouldn't be perfect in 3 months. It takes much longer. To reach your peak, it can take anywhere between 6 to 12 months. It is dependent on your age, your fitness level, and how your prehab has been prior to the surgery. So lots of factors, but typically I would say if you want to get back to sports, if you want to lead a very active life, it's between 6 to 12 months of recovery time. Again, the published evidence suggests that for younger people who are more fit and active, the recovery is quicker and the chance of success is higher. So for an under 30-year-old person who's having a pelvic osteotomy for dysplasia, 90% would be expected to have decent level of pain relief and be active. And that pain relief will continue for around 20 years. Now, if you are old, especially if you're older than 40, the recovery is slower and the chance of success also would be lower. Most likely because of the duration of problems that have been going on. So basically, if you've had a shallow socket and you've been living with it, then there is progressive cartilage damage over time, and that reduces the risk, or reduces the chance of success of the surgery. And therefore, older patients, the chance of success is anywhere between 80 to 85%. Again, if arthritis has not set in.